The topic of today's lecture is adrenergic agonists, and we are starting now adrenergic system and the drugs that act on adrenergic system. And there are two groups of drugs. One of them is called sympathomimetics, that is the drugs that act like a sympathetic nervous system. And another group is sympatholytics, the drugs that block the sympathetic nervous system action. And these two groups are very commonly used in clinical practice, and that is why it's very important to understand the action of this drug. And sympathomimetics include the drugs that are stimulating the adrenergic receptors, and they are divided to direct acting and non-direct acting. And 1 minute, it's lagging. So the direct acting agents include epinephrine. Epinephrine is the most commonly used agent, and also selective beta 1-dobutamine and beta selective isoproterenol, as well as other direct acting agents that are beta or alpha selective. And there are also indirect acting agents like amphetamine and cocaine. Cocaine is not a drug, but it's a drug of abuse. And also the mixed direct and indirect acting sympathomimetics, ephedrine and pseudoephedrine, that is a derivative of the ephedrine. So ephedrine is obtained from the Ephedra aquacetica, that is a common medicinal plant. So the adrenergic neurons release norepinephrine, that is a primary neurotransmitter in peripheral and also a neurotransmitter in the central nervous system. And the sympathomimetics act as a norepinephrine, and they stimulate the adrenergic receptors. These receptors can be located either on the presynaptic membrane or on the postsynaptic membrane. Also the epinephrine is released by the adrenal medulla to the blood, and then will act on the adrenergic receptors in the vessels and heart. So the structure of the adrenergic receptor is almost the same as for the cholinergic receptors. The only difference is that the neurotransmitter is a norepinephrine, not acetylcholine. And there are also the same steps like synthesis, uptake, release, binding to receptor, removal, and the metabolism. So the synthesis of the norepinephrine is done from the amino acid tyrosine that is contrasted to the nerve terminal with the sodium ions, and the hydroxylation of tyrosine leads to the synthesis of the deoxyphenylalanine or DOPA. Deoxyphenylalanine is a bypass product, and it can be metabolized by the enzymes, or it can be converted to the dopamine, and then the dopamine will enter the vesicles and will be converted to norepinephrine inside the vesicles. Some drugs that inhibit the sympathetic transmission, they're called the sympatholytics. So like for example, reserpine is a sympatholytic that inhibits the transport of dopamine into the vesicles. Then the dopamine converts to norepinephrine, and norepinephrine is released from the vesicles into the synaptic cleft, and then it can act on the presynaptic receptor, that is usually alpha 2 receptor, that will further inhibit the release of the norepinephrine, or it can act on the postsynaptic receptor that is located on the membrane of the effector organ, and that is usually beta 1, beta 2, and alpha 1 adrenal receptor. And after that, the norepinephrine is metabolized by the catechol methyltransferase, or COMT, and then also the metabolism can be reuptaken, so it can be also reuptaken by the nerve terminal, and also then used to move to the vesicles and released again. So there are two main classes of adrenal receptors, alpha and beta, and these receptors are differently bind to the epinephrine, norepinephrine, and isoproterenol. And epinephrine has a higher affinity for the alpha receptors, while the isoproterenol has a higher affinity to beta receptors. The presynaptic receptors are usually alpha 2, and activation of these receptors decreases the production of cyclic adenosine monophosphate, and that leads to the further inhibition of the norepinephrine release from the neuron. And postsynaptic receptors are usually alpha 1, but can also be beta 1 and beta 2. And activation of these receptors increases production of uh, diacylglycerol and inositol 3-phosphate, leading to an increase in intracellular calcium, and that intracellular calcium usually increases the contraction of the muscle. Um, there are further subdivisions of receptors, like uh, alpha 1 is further subdivided to alpha 1A, alpha 1B, and alpha 1C, as well as D, and the same is for the alpha 2. And sometimes it's necessary to understand the selectivity of some drugs. For example, tamsulosin is a selective alpha 1A antagonist and is used to treat the benign prostatic hyperplasia, uh, and uh, but for most of the drugs this classification is not much useful, so that is why we mostly will focus on alpha 1 and 2 receptors rather than alpha 1A, alpha 1B, and C. Beta receptors are also divided to three major subgroups: beta 1, beta 2, and beta 3. And beta 1 are located in the heart, and beta 2 are located in the vessels, and the so beta 2 are located only in those vessels that are that lead blood, that provide blood for the skeletal muscles, and beta 3 receptors are involved in lipolysis and also have effects on the detrusor muscle of the bladder that usually keeps you from voiding. Binding of the neurotransmitter at any of these three receptors results in activation of adenylyl cyclase, that increasing this concentration of cyclic adenosine monophosphate. So the same as here. So same as presynaptic alpha 2. The stimulation of alpha 1 receptors produces a vasoconstriction, while stimulation of the beta receptors usually produces the tachycardia. So the long duration of action of the catecholamide reduces the responsiveness of all receptors, alpha and beta, and that is called a desensitization. There are several mechanisms that explain this phenomenon, and one of them is sequestration of the receptors, so they are unavailable for interaction with the ligand. Second is down regulation, that is a disappearance of the receptors either by destruction or by decreased synthesis. And third is inability to couple the G protein because the receptors has been phosphorylated on the cytoplasmic side. Um, Most of the adrenergic drugs are derivatives of the catechol, that is phenylethylamine the derivative. So uh, and most of the drugs have some substitutes on the benzene ring, and that that gives a selectivity to alpha or beta receptors, and also the uh, resistance to the enzymes, to the uh, enzymes that destroy the drugs. So uh, the catecholamines contain this group, that is 1, 2, 3, 4, 3, 4 dihydroxy benzene ring, and we have 4 drugs with this catechol group, that is norepinephrine, isoproterenol, and dopamine. So all these drugs have a high potency, and they activate both alpha and beta receptors. They are also inactivated by catechol O-methyltransferase, and also by monoamino oxidase. Sorry. The latter is located in the blood. These enzymes are also located in the gut wall and in the liver. For this reason, catecholamines, including the epinephrine specifically, have short duration of action, and they are also ineffective when administered orally, so they should be given intravenously. They also penetrate poor to the central nervous system, and that is why they will not affect much on the central nervous system. The other group is the non-catecholamines, and they don't have these hydroxyl groups, and that is why they have longer duration of action, and these drugs include phenylephrine and ephedrine and amphetamine. So ephedrine is actually shown here, phenylephrine looks almost the same. So ephedrine has only benzene ring, and that is why uh, is not metabolized by the enzymes, and also it enters the central nervous system because molecular is lipophilic due to these methyl groups. And the selectivity of the drug is determined by the substitution in the amine, and the norepinephrine is mostly alpha, at more on alpha receptors. Epinephrine has a little stronger beta component, and isoproterenol has only beta, is pure beta uh, mimetic because of the isopropyl uh, isopropyl group uh, uh, connected to the amine. Uh, so almost no alpha activity for the isoproterenol. The mechanism of action of the adrenergic agonists can be direct. Direct action is the same as for the norepinephrine. So the drug is activating the receptor that can be on the postsynaptic or presynaptic. So here it's on the postsynaptic. Usually this is a muscle, and this is a direct action. So most of the drugs are direct acting drugs. Second group is indirect action, and indirect action actually ephedrine, sorry, or actually the cocaine and amphetamine, and these these can enhance the release of the norepinephrine from the vesicle or decrease the reuptake. And there is also a third group that is mixed action agonists like ephedrine and pseudoephedrine that can do both. And direct acting agonists bind to adrenergic receptor on effector organs without interacting with the presynaptic neuron. And ephedrine is most commonly used drug in the world today, and norepinephrine is the natural analog of the epinephrine, and epinephrine is stored in the chromaffin cells, as well as the norepinephrine, but there is more epinephrine in the adrenal medulla, and approximately 80% of the epinephrine and 20% of norepinephrine are released during the stimulation of the adrenal medulla, and epinephrine mostly acts on beta receptors, and it increases the heart rate and force of the contraction of the heart. It also increases the systolic blood pressure and decreases the diastolic blood pressure. It also decreases the peripheral resistance. Uh, Increase in the heart rate is due to the action to beta 1 of the heart, and decrease in the peripheral resistance is because of the stimulation of beta 2 receptors on the vascular of the smooth muscles. Uh, the epinephrine also activates beta 1 receptors of the kidney, and that increases the release of the renin. And renin is an enzyme that produces angiotensin 2, that is a potent vasoconstrictor, and that is why the arteries are constricting, and that increases the systolic pressure, but it relaxes the veins of the liver and skeletal muscle. This is beta 2 effect, and that that is why the diastolic pressure is decreased. And the also epinephrine is used for the treatment of the bronchoconstriction with the intramuscular intravenous injection, and also cutaneous injection, and also it can be used for the treatment of the anaphylactic shock because of the allergy, and can be injected intracardially to the patients with the cardiac arrest, and also it is added to the solutions of the local anesthetics in a very low concentrations, that increases duration of the local anesthesia by producing vasoconstriction at the site of injection, and that also decreases the absorption to the systemic circulation and decreases the side effects of the anesthetics. The onset of action is very rapid, especially when injected intravenously. It can be also used as aerosol, and the duration of action is short because of the rapid degradation, and intramuscular route has a faster absorption rate, and in emergency it can be given intravenously. That gives even more rapid onset of action, but also is duration of action is also shorter. The metabolites are excreted in the urine, so the route of elimination is by urine, by kidneys. Adverse effects include central nervous system, anxiety, fear, tension, headache, and tremor. It can trigger cardiac arrhythmias, particularly if the patient is receiving digoxin, and epinephrine can also induce pulmonary edema and epinephrine is contraindicated for the patients with hypothyroidism because of the increase of the production of adrenergic receptors in the vascula that can lead to the hyper-responsive action. The epinephrine increases the release of endogenous stores of glucose, and that is why in diabetic patients dosage of insulin may have to be increased. Non-selective beta blockers prevent vasodilatory effects of epinephrine on beta-2 receptors, and that may lead to the increased peripheral resistance and increased blood pressure. So second drug is norepinephrine. Norepinephrine is the neurotransmitter of the adrenergic nerves, and norepinephrine acts on a little bit different, so mostly vice versa. So if we compare the action of the norepinephrine and epinephrine, their actions are almost opposite. Norepinephrine induces bradycardia, that is reflectory, because it mostly acts on alpha receptors, less beta. That is why the reflex bradycardia is seen, and it increases the systolic and diastolic blood pressure. It also increases the peripheral resistance. Then norepinephrine causes greater vasoconstriction than epinephrine because it does not induce beta-2 vasodilation, and that is why it's not useful in the treatment of asthma or the anaphylactic shock. So almost no B2 relaxing activity. Also, norepinephrine increases blood pressure, and that stimulates the baroreceptors, and then that increases the activity of the nervus vagus, and that leads to the reflex bradycardia. The norepinephrine sometimes used to treat shock, but mostly the epinephrine is used for this purpose, and that is why norepinephrine is not clinically useful. However, it can be given intravenously, so actually the same as for the epinephrine, and the same direction of action is short, about several minutes, and because it's rapidly metabolized to the inactive metabolites that excreted in the urine. So actually the same as for the epinephrine, metabolites are in urine, intramuscular, but there is no aerosol or subcutaneous injection, mostly intravenously. The adverse effects same as for epinephrine, and additionally, the slunging of the skin can be seen at the site of the injected vein. Sometimes it can lead to the tissue necrosis because of the contraction of the vessels. That is why it should not be administered in peripheral veins, because that can lead to the necrosis. And the antidote is phentolamine, that is alpha receptor antagonist phentolamine. We will study phentolamine next week. So, and the third is isoproterenol, that is a direct acting synthetic catecholamine that is mostly stimulating beta 1 and beta 2 adrenergic receptors, and isoproterenol produces stimulation of the heart, and it decreases diastolic blood pressure and slightly increases the systolic blood pressure, and it decreases the peripheral resistance because of the action to the beta 2 receptors, that is vasculature of the skeletal muscle. And isoproterenol used as a bronchodilator because of the beta 2 vasodilating effect. And the adverse effects are the same as for epinephrine. So the summary of action is here, like isoproterenol used for bronchodilation, peripheral vasodilation and bronchodilation. Then increase this cardiac output because of the beta 1, and then increases the blood flow in the kidney. It is dopamine. So these are the actions on the of the isoproterenol and dopamine. There are several drugs nowadays that are used for bronchodilation, including the terbutaline, albuterol, formoterol, and salmeterol, and these synthetic drugs are longer duration of action, and that is why they are preferred now and mostly replace the epinephrine, because of the convenience of use, like the aerosol, a fast onset of action, and less side effects because of the local action. Adverse effects of the cholinomimetics include arrhythmias, headache, hyperactivity, including insomnia, and also nausea and tremors in high doses. Insomnia is also in high doses, so most of these side effects are seen in high doses. So that is all for today, and thank you for your attention. And looks like the presentation, the broadcasting was not active anymore. So, but no one reported to me. Okay, good. So hope you can watch this recording. The Hope you can watch this lecture on my channel on YouTube, because I will publish it later. And don't forget to subscribe to the channel if you are not subscribed yet, and check the thumbs up, and drop me a comment so we can discuss this later at the practice. See you next week, and bye bye.